Hi, everyone. Good afternoon and welcome. My name is Laura Lane, and I am the Deputy Director for Women's Health at the Department of Public Health. I hope you all had a wonderful holiday. Thank you for joining, and we are fortunate to have Dr. McGlure to present and teach us more about implicit bias today. So we're looking forward to that. I'm going to give a few updates and an intro. I put in the chat box, but if you are on the webinar and you can enter your name and participating team members and facility, that would be helpful for us. Also, please mute your lines and do not put your phone on hold because we cannot control that background noise that comes on when the lines are on hold. We will have time for discussion following the presentation, and we would love to hear from you all, and we encourage you to share your highlights, lowlights, successes, and challenges. So there's no changes to the hemorrhage driver diagram, but it is here for reference. Also, the hemorrhage goals, there are no changes here.
Laura?
Yes, ma'am?
I'm sorry to interrupt you. This is Missy. I'm not seeing your slides. I'm not sure if other people are, but I'm not currently seeing them.
Okay, thank you so much.
For sure.
Let's see how I can do that. Okay. I think I figured out how to do it. Give me just 1 second. Okay.
That did it. Thank you.
All right. Thank you so much, Dr. Kaki. Okay, so the hemorrhage driver diagram is here for reference. Our hemorrhage goals also have not changed. For our structure measures, you're all familiar with these and reporting on them. So we'll show some baseline data in just a minute to highlight where we are as a collaborative. For process measures, the update is to include provider and nurse implicit bias training. And this will be the first quarter that we collect data for these measures. So this is a graph of the structure measures for hemorrhage for the period April of 2018 to September of 2019. And we're making a lot of progress. One example is with the S2 measure, debriefs. We've increased from about 20% implementation rate to 74.1%. And we see increases across the board in all 6 measures. So this graph shows process measures for hemorrhage during the same time period. And we're also making a lot of progress here too. As an example, with hemorrhage provider education, this increased from about 20% implementation rate to 63.2%. And again, we see increases with all the measures. Hemorrhage nurse education, hemorrhage protocol nurse education, and hemorrhage risk assessment are all reaching 84.4% implementation rate. Excellent. So does anyone have any questions about where we are looking at the key driver diagram, the goals, or any of the structure or process measures? All right. Well, we will move to our presentation, and it is my pleasure to introduce Dr. Zita McGlure. She is a board-certified family physician currently in private group practice in Cairo, Georgia. She is currently the chair of the Department of Obstetrics and Pediatrics at Grady General Hospital, and also is the Georgia Academy of Family Physician liaison to the Georgia Perinatal Quality Collaborative. Dr. McGlure also serves as the chair for the Obstetrics Member Interest Group for the American Academy of Family Physicians. Her passion is treating whole families with a special interest in maternal health and patient advocacy. So Dr. McGlure, we're so excited to have you today, and I will turn it over to you. We're looking forward to your presentation.
Thank you. Can you hear me okay?
Yeah.
Yes,
okay.
I hear you great. Thank you.
Perfect. All right. Well, thank you for asking me to do this. I had a little bit of practice because I gave a similar talk to our nursing staff back in November at the labor and delivery staff meetings. So, but this is meant to be interactive. If anyone wants to buzz in with questions, comments, or answers during the presentation, I welcome that. It's very informal. I want this to be fun and hopefully introduce this topic in a way that you can go back to your facilities and hopefully share this information as well. So today we'll be talking about implicit bias, and to get started, we can go to the next slide, go to the learning objectives. Very simple, just 2 things. So we just want to know what it is, define implicit bias, and describe its effects on patient health and outcomes. And then we're going to identify strategies to mitigate implicit bias in the care of specifically of pregnant patients and pregnant and postpartum patients. And so the focus on implicit bias is because of collaboratives like the Georgia Perinatal Quality Collaborative. We know that social determinants of health really are impacting our maternal mortality numbers. And so wherever you have social determinants of health strongly impacting your outcomes, we know that implicit bias is going to be playing a role. So just being aware of it and learning how we can work with our own human psychology is kind of fun, and hopefully will be impactful for our patients. So we can go to the next slide. Okay, sorry guys, I have a quiz, icebreaker quiz. So these are just, there'll just be like, I think there's 4 questions. If you want to jump in and answer it, you're fine to do that. Or at the end of the 4 questions, we're going to kind of give everybody a chance to make some comments. So the first question is, when do the majority of pregnancy-related deaths occur? I think this is supposed to say during pregnancy and within the first 6 weeks postpartum, but I may have typed too fast. But anyway, so within the first 6 weeks postpartum, during the 3rd trimester, or after a patient stops breastfeeding. Okay, let you guys mull on that for 2 seconds. And we'll go to the next slide. Next question is, what factors increase risk of maternal mortality? And so we have the patient's age, patient's race, where a patient lives geographically, or all of the above. And we'll go to the next slide. Members of the healthcare team, true or false? Members of the healthcare team are usually aware of their own implicit bias. True or false? And I think our last question, this is our last question coming up. Aha. Who, out of these lovely young ladies, is more likely to die during pregnancy and the postpartum period? And so I'll give you a few more seconds to kind of look at these ladies, not stereotyping, but you can look by their physical features, and I'm trying to highlight the ethnic differences in these patients, these ladies. One of them is me, by the way. So, okay, we can go to the next slide. All right, so we're going to go over those questions, kind of give yourself a self-check and think, okay, how did you do? Were these pretty easy, or were you kind of not sure? So for the first question, when do the majority of pregnancy-related deaths occur? Most of them are during pregnancy and the first 6 weeks postpartum. Actually, most, 36%, happen the day of delivery or within that immediate postpartum period. Another third happen usually within the 3rd trimester, and then there's another third 1 week to 1 year postpartum. So really the majority happen during pregnancy and that immediate postpartum period, which is why it's so important for us to be aware of signs and symptoms of maternal complications, even as they transition maybe back to their primary care doctor or they present to the emergency room. The second question was about what increases the risk of maternal mortality, and the answer was all of the above: age, race, and where a patient lives, which is another indication, especially with the racial disparities, that perhaps there are things that we can do to mitigate that risk as well. And then, as we're going to see in the next couple slides about implicit bias can be unconscious as well as conscious. So, and actually most people are not aware of implicit bias. And it's not the same thing as prejudice or even stereotyping. So I think that's going to be an important distinction to make. And the last one, actually, if you could go back to that last slide with the picture on it so I can explain myself. This is what I did for our nurses, just to kind of bring it home. So there's 3 OB docs in my hospital. Myself, I'm in the green shirt, and then my 2 partners are in purple and then the coral shirt. One of the purple shirt is of Caucasian, and the coral shirt is Hispanic, Hispanic background. It was just, I thought this was like a good teaser for the nurses to kind of start thinking about us, not just as, you know, we're all the same, we're all doctors, we're all educated, we're all about the same age, but that, you know, one of us has a much, much higher risk, even when you control for education, of death during the hospitalization, during pregnancy and postpartum. Anybody want to guess which one of us it is? Throw it out there. I hate to say it. It's me. So it's African American, Black African American, also Native American, Alaskan Natives also have a much higher risk as well. And it's just baffling. You know, you think that it would not be that way, but it is. So let's go on to not the next slide, but the slide after that, and start talking about implicit bias. So it is defined as the attitudes or stereotypes that affect our understanding, actions, and decisions in an unconscious manner. It also can be called unconscious bias or implicit social cognition. You know, that word bias just has a bad ring to it, and I kind of like the implicit social cognition, but it's a little wordy. So maybe you can find a different word that doesn't maybe get people a little on the defensive side when we're trying to talk to our colleagues and our staff about it. But it is a contributing factor to healthcare disparities. Let's go to the next slide. Okay, here I've listed just some types of implicit bias, but there are probably several more. These are some very common ones, and some of them are kind of self-explanatory. The next slide, we can go ahead and go to the next slide, and you can maybe screenshot it if you want to keep it for your records. But here I've actually defined some, and so later on we're going to have a case, and it would be really fun if we can just go through these really quick so we all understand what they are and see how they apply in the case at the end of the presentation. So affinity bias, it's just we have affinity where we like people that we are similar to us, which makes sense. And it's, again, not something that we necessarily do consciously, because I think we all probably have you know, friends and people that we like and colleagues that aren't necessarily like us, but it is something that just based on our own social nature is just part of who we are as human beings, and we should just be aware of it. I do want to spend a little bit of, or make a little emphasis on the next one, anchoring bias. And this is really not, this is not specific to maternity at all. If I don't know what the makeup is of the people on the call, nurses, other healthcare staff, you know, staff, administrators, but an anchoring bias is basically we get a piece of information and we stick with it, and it's very hard for us to look past it. And in medical training, we call it getting tunnel vision, and it can really, I mean, it can really prevent you from seeing a very serious problem. So, for instance, someone comes in the ER with chest pain, and you're thinking cardiac, 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 and you miss a pulmonary embolism. So this is very common, but it also really does affect maternal outcomes as well. Confirmation bias is basically where we think something already, and so we look for things to confirm that bias. I mean, this is basic human psychology. Again, this is, and it's not meant to be punitive, like, what a terrible person. We all do this, and so I think normalizing it to an extent helps people be able to accept that this exists and then want to address it. Otherwise, people get very defensive and say, what are you saying? I have a character flaw or something? There's something wrong with me. There's nothing wrong. This is just how we, our default thinking. We just need to kind of get past that. Conformatory bias, I didn't say conformatory, conformity bias is basically where, you know, let's say all of your medical colleagues think something is correct and they've got the diagnosis, you think you may have another thought, but you're afraid to say it because you want to conform to what the rest of the medical staff is thinking. Last two, the contrast bias is basically where...
An excellent choice. They love that. The transport.
I don't know if maybe we got a mute phone here. The contrast bias is where, you know, we think about a patient maybe that we've had in the past, and then we kind of use that patient to compare to.
Mm-hmm. Yeah.
The best way to, you know, manage patients. Each patient should be managed as an individual. And of course, gender bias, which is probably why this affects maternity so much more, is because there is a gender bias, and unfortunately for healthcare, I think it probably negatively impacts women more. So we'll see that. So that is the biggest slide in terms of information, and now we're going to kind of go into the case, and we're going to try to use some of the things that we've, okay, oh, wait, got one more slide before the case. So be thinking about this too, mitigating implicit bias, 3 ways that we can work to not fall into this pattern. So awareness, we're already doing that. And then protocols, which if you're part of GaPQC, you're and then case reviews. And so maybe at the end we'll have an opportunity to talk about how your facility deals with, you know, certain outcomes like a postpartum hemorrhage or an undesirable outcome, and how those cases are reviewed. So we can skip on to the case now. Next slide. Okay, so I was trying to get this really fast, so hopefully, but this is not just one patient. I've seen several patients like this, so this is actually very common, unfortunately. So Nina is a 23-year-old gravida 1 female at 37 weeks gestation. She had her ultrasound was a second trimester ultrasound. It was actually done in the ER earlier in the pregnancy because she really didn't have prenatal care. She presents to labor and delivery, reporting nausea, headache, and malaise for the last several days. So she has not had prenatal care and states this is due to moving recently and being unable to get her pregnancy Medicaid approved. At her last ER visit, she was positive for marijuana, and she is positive for marijuana again at this visit. When she is brought back for evaluation, she is on the phone apparently arguing with her boyfriend and is visibly upset. Go to the next slide here. So, okay. So, oh, go back one slide, sorry. Geez, go back. Sorry. Okay, so the next slide is just general observation. So before, I've listed some on the next slide. If we just maybe take like 60 seconds, if anybody would like to maybe just express like some just general observations, and they don't have to be like negative observations or positive observations. Just what are your thoughts about this patient? What thoughts come to mind about what might be going on with her in terms of socially, things like that? Anybody have any thoughts about that, comments? Okay. All right, I'll help you guys out. We can go to the next slide then. Okay. So the reason that I divided the observations up into positive and negative is because implicit bias doesn't necessarily have to be negative. You could have positive biases about a people group or a certain person. And I'll give you an example from our own hospital. I practice in a small town. We have a very large Hispanic population, but it's a diverse population. However, there are a subset of the Hispanic patients that we see that typically from our general observation do not require or request a lot of pain medication or an epidural during labor. It's just whether it's a language barrier, whether it's culturally just different, whether they're not aware that they can ask for it. There's several possibilities, but in general, They don't get any pain medicine, and they do phenomenal, okay? So it's kind of like a bragging thing. The nurses love to brag about how great they did. But you could see maybe where this could be problematic. So another Spanish-speaking patient comes in. It's not everybody feels the same. What if that patient really does desire or want pain medication? But because we're used to, or our staff may be used to them not requesting it, maybe we don't offer it like we do with some of our other patients from another demographic. You see, it's not meant to be like necessarily a negative thing, but you can see how it can impact a patient's outcome in that respect. So again, this can be both positive and negative. So about Nina, you know, maybe we think about Nina and we say maybe she's in an abusive relationship, maybe she has economic difficulties, maybe she's unable to get adequate care, but we also could very quickly think about her in a kind of a negative way too. So even though she's positive for marijuana, which in some states is not even illegal anymore, we could probably label her as a drug user, and then we may have developed an anchoring bias that she's a drug user, so therefore any of the abnormalities that we see maybe in her blood pressure or her other labs, even though marijuana shouldn't elevate your blood pressure, maybe that's why. She's irresponsible, or maybe she has a dysfunctional relationship, so maybe there's some character issues with her. So these are just some general observations that we make very quickly and we don't even realize it, but it can contribute to how we can unconsciously apply biases to this particular patient. Let's go to the next slide. Her exam, let's see. What I did was I relisted some, the implicit bias lists again, just so you could have them on your mind as we go into her exam, okay, and the rest of this case. So this is her assessment, and I'll only point out the things that kind of stand out as abnormal. Her blood pressure is 155/98. Her weight is 240 pounds, and she reports that she was 180 pounds. That was her pre-pregnancy weight. Her fetal monitoring is completely normal. She's not having contractions. Everything looks great. Her exam is really only notable for 1 or 2 plus edema to the bilateral mid-calf symmetrically. And she does have, the only lab analysis she does have a urine dip that was positive for 1 plus blood and 2 plus protein. They did send off for a urine protein creatinine ratio, but as it was nighttime, as this is how it is at our hospital, it is a send out, and so the results usually don't come back till the next day, unless you call the courier. They didn't call the courier, so let's go to the next slide. Okay, so so we started out with our initial observations about Nina, and this is where it can start impacting her health. So I labeled this slide when objective findings become subjective, and it's when we try to reason why we see something based on our perception of the patient. So I mean, and you guys don't have to look at the slide, or maybe there's other thoughts you all have, but and if anyone does, please speak up. But we find that she has hypertension. Obviously, hopefully, she would get her blood pressure rechecked at least 2 or 3 more times before she would be discharged. But what about the perception that her high blood pressure is really due to something else other than a diagnosis of hypertension? Maybe she's overweight. Maybe she's arguing and she's stressed. Maybe she has anxiety. And I hope this sounds familiar to you guys, because it's certainly familiar to me. This is a lot of the times what we hear. Her blood pressure was this, but. And so we have to be careful with that. Her excessive weight gain. She really hasn't had prenatal care, so we don't know the time course for that weight gain. But it would probably be pretty easy to say, well, maybe she just hasn't really done anything. Maybe she hasn't gotten prenatal care. She's irresponsible. Maybe she's just lazy. That's why she's gained weight. What about her swelling? Well, we could normalize it and say every pregnant woman swells. And by contrast bias, every pregnant woman swells. That's normal. Or maybe she's overweight. And again, the headache, the same thing. Maybe she literally I know this happens. You know, we know that she's positive for drugs. Maybe we feel like she's stressed because she needs to use drugs. And that has come up before when I've taken care of a patient. So all of these things are where we have to really be careful about maybe our initial impression about a patient, not recognizing that maybe we're focusing too much on that initial presentation, that anchoring bias, and that we really need to take a more objective approach to their assessment. So let's go to the next slide. Okay, let me see where we are in my slide deck here. Oh, good, we're almost done. So this is Nina's outcome. So Nina was discharged after a period of observation, though she still had a mild headache after being given Tylenol and a combination, I wanted to use the generic, so butalbital, acetaminophen, caffeine. She was given a list of OB providers to establish care with. She's 37 weeks. Time is of the essence. 48 hours later, she returned to L&D with severe range pressure, severe headache, and elevated liver function. So she's at least has severe preeclampsia at this point. She was admitted and was attempted to be induced, but had to have an emergency C-section for non-reassuring fetal heart tones, which were found to be due most likely to a partial placental abruption. She decided not to breastfeed as she was sick and exhausted after being treated with magnesium sulfate and being transfused 3 units for postpartum hemorrhage. She and baby were discharged home on post-op day 5 in stable condition. So let's go to our last slide, our wrap-up slide, so we can talk about Nina and her outcome. So now this is our last slide. So before we just have general questions, so if anybody wants to unmute and answer or make a comment, now's the time. So what role, we've talked about implicit bias, and we've talked about how it can be, it's usually unconscious, and the different types of implicit bias. But specifically in this patient, what, in terms of her outcome, having an emergency C-section, not breastfeeding, requiring a blood transfusion, developing severe preeclampsia, what role do you feel, if any, that implicit bias may have played in this scenario? If anybody wants to comment. Let's see. Anybody?
I wasn't here at the start.
Let's see, somebody wanted to comment?
This is Jennifer Rosenovich. Maybe we would have kept her and treated her sooner and she wouldn't have gotten a C-section.
It's possible. It's very, I didn't give a lot of information. I mean, there could totally be scenarios where, you know, maybe we checked labs and we did everything we were supposed to and she still came back preeclamptic. But just the thought that we maybe should have slowed down, maybe completed the evaluation and just made sure she had good follow-up. I mean, this patient's already 37 weeks, probably doesn't have the best follow-up, so it's definitely something to, you know, just be aware of. So good.
This is Missy Kotke. One of my favorite things that you commented on that really resonated, and I anticipate resonates with every single person on this call, is the she has but, right? Like she has this but. And I think that happens, we do that all of the time. And I think some of it may have factors like implicit bias at play. And also there are sometimes I feel other things going on, like you're always trying to do the best calculus that you have with the information that you've been given, you know, and there are some people like you know how getting mag feels, and so you only want to give magnesium to the people who need getting magnesium, and so I think that there is sometimes those kinds of things at play as well. But for me, it's such a powerful thing to hear, thinking about how so much of what we're trying to work in this quality collaborative towards is to highlight opportunities to improve denial and delay in our management for patients. And so for me, I think that was a really powerful just soundbite for me, and for me to make sure my residents and students and other team members know is like anytime you're having a but, it's a really great opportunity to pause and to kind of just reassess the fullness of the situation. So thank you for that.
Thank you, Dr. Hotkey. It's very helpful feedback. It's welcome anyone else to comment. I'll just go to the next bullet point. What are some strategies, and we were already doing this, which is fun, but maybe some of the other hospitals on the line, maybe you guys have some more specifics on what you're doing, but what are some strategies that the hospital could use to mitigate the risk of poor patient outcomes due to implicit bias? I'll just say one of the things, and I correct me if I'm wrong, I think that part of the Joint Commission's the last maternity call, did we say the Joint Commission is now requiring that this is part of the, or maybe it's a collaborative that is now part of the structure measures that we're doing as the implicit bias training, is that right? I want to make sure.
Yes, that's exactly right. We've added implicit bias training for providers and nurses as part of our process measures for all of our GaPQC activities. And some of our data collection is also going to be stratified on race ethnicity as a place to start. There are probably more inequities, but certainly to your point, that's the most egregious that we know about that we have to start making progress on. And so we've added the implicit bias training process measures. And then I anticipate Laura has a slide or two at the end of this talk about some trainings that we'll be offering. And then this will also be something that we're discussing at our annual meeting just to hopefully help us all collectively increase our awareness and hopefully be able to move the needle on some of our disparities.
Yeah, great. That's wonderful. Having a hypertension protocol in the hospital is a great way where, with certain presentations, with certain symptoms, like the headache that didn't really go away, that is, evaluated in a systematic approach, as opposed to, kind of depending on whoever's on and how awake they are when the nurse calls them. And so I think that helps. I think that helps everyone on the healthcare team and the patient as well, when that can be instituted. And then the other thing is, the last point, how would your institution review or debrief a case like this one? And so I think all the hospitals probably that are participating in the collaborative, they're striving to do better and probably have something in there already where they're reviewing cases. But, our cases, even before that we were participating in the collaborative, they were flagged for certain outcomes. So if there was a postpartum hemorrhage, if there was a neonatal transfer, if there were, if someone got if the patient got a blood transfusion, those cases were already flagged. And so, it's really important that, maybe we flag cases. I mean, if we're trying to look for implicit bias, maybe there's other cases that we can flag. Maybe we make sure that we flag cases that include a diverse population of patients, making sure that we flag enough cases maybe with our African American patients, so that we can, see if there's, a relationship or pattern in some of the outcomes. Sometimes just like a random review, looking at certain demographics can be helpful as well. And that's all I have. I think the last slide is just hey, anybody got any questions? But I really appreciate your time, and good luck at your institutions. So.
Thank you so much, Dr. McClure.
Thank
you.
You
are so knowledgeable about this topic, and we are fortunate to have you on our webinar today. Thank you again.
Thank you.
If anyone has any final questions, you can go ahead and unmute and ask now.
Laura, this is Missy. I noticed that Lois Hirschberger had a comment in the chat box about kind of nursing follow-up after discharge, and I think that is a great idea, and thinking about pragmatically what could be done to offer additional support. Lois, I don't mean to call you out, but I don't know if you want to add more or clarify what your institution is doing.
Can you hear me?
Yes.
Okay, I wasn't sure. So I think my point, I should have made it more clear. My point is that maybe too often we nurses sort of just parrot whatever the doctor says about their follow-up, but I'm talking specifically about nurses being more proactive about finding out, especially with people with who have made poor choices or maybe a poor history, making sure that they have services available such as transportation, taking the responsibility to make sure that people that have been admitted or observed for hypertension, that they have a follow-up within 2 to 3 days. I've been a nurse for 30 years, and we too easily just sort of parrot or sort of, in some of those ways, we have just always sort of done what the orders said, but I like the collaborative, which calls us out more to being proactive about that, and that's probably more my point than anything.
Thank you.
Thank you. Is there anyone else? Okay. Well, thank you very much, Dr. McClure. We appreciate you being on the webinar today, and I know you have to run to your next thing. But we do appreciate your time and your wealth of information on this topic.
Thank you, guys.
And I wanted to share with everyone as well that we are working with the Institute for Perinatal Quality Improvement to offer implicit and explicit bias speak-up training. This is a one-day training, and we hope to offer a couple beginning late spring, early summer of this year for a large group of about 100 participants for each training. So stay tuned for save the dates and more info to come on that. And finally, we're also working with our perinatal outreach educators to host regional trainings across the state. We're looking at about 5 locations, and the training will offer both high and low-tech simulations, and will standardize the curriculum for each site. So we're thinking the same time frame, late spring to early summer of this year. We're really excited about both opportunities, and more info to come on that. And our save the date for the annual conference this year, April 23rd and 24th. And I'll open up the line again if anyone has any questions or would like to share any experiences on the webinar today. The chat box looks good. All right. Well, thank you, everyone, for joining, and we will look forward to talking again in February. Have a great afternoon. Bye-bye.